Good morning and welcome, everyone. This is Kate Myers, Senior Program Officer at the California Healthcare Foundation. As many of you know, the California Healthcare Foundation has been engaged in a variety of efforts around improving serious illness care and end-of-life care in California for over a decade now. And in the last several years, we've been involved in a number of different types of technical assistance and support around preparations for and implementation of palliative care services under Medi-Cal's requirements related to Senate Bill 1004. And I'm really thrilled to be with you today, though I miss seeing you all in person. I think as many of you know, today was supposed to be our second annual statewide convening on driving improvement in palliative care in Medi-Cal. And we had to cancel it for obvious reasons, but I know, so much has changed for all of us in the last 4 weeks since we decided to cancel the meeting. And I just want to say how much I appreciate you all for spending time with us here today amidst what I am sure are a lot of competing priorities and demands. And I hope that the webinar series today provides you with a little bit of a respite and break from thinking about COVID-19, but I appreciate that you're dedicating the time to today. I also want to especially thank the team that led the planning of this work. That includes Chris Wallach, Chief of Programs at the Coalition for Compassionate Care of California, Kathleen Kerr, an independent healthcare consultant who'll be presenting in just a few moments, and Dr. Ann Kinderman of Zuckerberg San Francisco General Hospital. It's a wonderful planning team, and I thank them all for their work. I also want to thank all of you participating in this webinar for the work you did in completing the surveys that we sent to health plans and provider organizations around the state, because those responses and that content is what created our first two webinars today. So thank you for the time that you put into that. Before we get into some logistics, I want to just ask Judy Thomas, the CEO of the Coalition for Compassionate Care of California, our partner in this work, to say a few words. Judy?
Great. Thank you, Kate, and thank you to everyone who is on this webinar today and those who will be joining our other webinars later today. As Kate said, thank you for being here in the midst of this current situation. I think this has really brought to light the importance of the work that we're doing with palliative care and promoting conversations about serious illness. I think that the teams, all of you who are doing this work, are playing an important role, that this pandemic situation would be even worse if we weren't where we are in the state with our knowledge and our capacity has been developed. One thing that the coalition is doing that I want to make sure that you're aware of is we're starting a campaign, an initiative to promote conversations related to COVID, calling it COVID Conversations, so that it's our effort to kind of help stem the surge so that it's not quite hitting our medical system as bad as it would be if we hadn't solicited people's preferences for care. So check out our website, sign up for the newsletter, listen to the webinars, and we'll be crowdsourcing materials as well to really help our whole society to engage, to leverage this time and engage in these really important conversations and become much more knowledgeable about serious illness and how we can all stay more in control of our health care. Thank you, Kate.
Thanks so much, Judy. Next slide, please, Kathleen. Okay, so just a quick review of logistics. I think many of you know this from the emails that I've sent over the past couple of weeks, but the way that we've restructured what was our in-person meeting is to basically present a part of what that content was going to be through 3 webinars today. That are basically back-to-back, but with some breaks in between so that you can attend to other things. The first webinar that you're on right now is Who is Being Served and How. We'll then have 2 more webinars looking ahead and examining quality. And I want to emphasize that folks are welcome to come to one or all of the webinars. Hopefully it was clear to you that you needed to register independently for each of those webinars. So the links that you have received for accessing the webinars, again, are a different link for each webinar. So please make sure when you're logging back in at 11:15, you use the link for the 11:15 webinar. Hopefully that's not too confusing. I want to emphasize that all the webinar recordings will be posted to the CHCF website, probably within about, 7 to 10 days or so. And I want to encourage everyone to please use the chat function that you have under Zoom, even more liberally than you might in an ordinary webinar. We're trying to replicate a little bit of what our in-person meeting would have been in terms of sharing and hearing from each other. So I encourage all of you, as the slide notes, to use the chat function to share observations or reactions to what you're hearing in real time, to ask questions. We'll try to address those at the end of the webinar as to the extent we can, or we can address them offline. And again, you can have kind of a dialogue in the chat box as you see other people's comments or questions. You can feel free to respond to them or describe what jumps out at you. So before we get started, again, I just want to thank the team that put this together and introduce our first speaker. So today, Kathleen Kerr will be presenting on webinar 1. Many of you know Kathleen, but she's a healthcare consultant in private practice in Mill Valley, California. Her work is focused on promoting the development of sustainable, high-quality palliative care programs with a particular emphasis on services that operate in rural areas and those that serve Medicaid beneficiaries. With that, I will hand it over to you, Kathleen.
Hey, thanks, Kate.
Sure.
So here we are, and I too really wish that that we were all together in a lovely hotel conference room, but we can't be. And I hope that the webinar does a little bit to fill that void. I know it's been just really a pleasure to look at the survey responses and analyze them, and have a chance to think about SB 1004. A little bit of a stopping and thinking, where are we at now, and then where are we going to go from here. So really looking forward to having an opportunity to share some information with you all today, and having a look at your chat comments as well. So I know that many of you are very, very involved in SB 1004 palliative care, either on the plan side or on the provider side or on the policy side. But in the off chance that some of the folks who've joined us today do not live and breathe this stuff, I'm going to start with just a really brief description of what SB 1004 is. And Senate Bill 1004, fondly known as SB 1004, was signed into law in 2014. It requires that Medi-Cal managed care plans ensure access to palliative care for eligible members. It was implemented for adults in January of 2018, and it was expanded to pediatrics in 2019. And I should note now, and I'm hoping it was clear in the registration materials, that everything that we're going to talk about today is for the adult side of SB 1004. We're not going to be diving into peds worlds in these 3 webinars. So one important thing to know about SB 1004 is that it's a very particular type of palliative care. And I'm sure many of you think of palliative care in its broad terms, which is extra services and supports to any individual with serious illness to help them cope, and it is available regardless of, it's appropriate regardless of diagnosis or prognosis or age. That's not quite what SB 1004 palliative care is. It's a benefit, and it's designed for a particular set of folks to be delivered at a particular point in time in the course of a serious illness. And you'll see in this schematic, which is available on the DHCS website, just put those words that are in the bottom right-hand corner of your screen, DHCS Palliative Care and SB 1004, into your favorite browser, and it will take you to a page that houses this schematic. You'll see that SB 1004 tucks in after someone has been coping with a serious illness for a while, but before they would be eligible for hospice care. So it's really intended for folks who are about in the last year of life. And there are eligibility criteria beyond just having a serious illness. There's sort of 3 buckets of them. One is general criteria, which looks at some utilization history, like if the person has been starting to use the hospital or the emergency department to manage their disease. There's also some patient and family preferences in there. You need to be willing to engage in advanced care planning, willing to do a trial of home-based care instead of, for example, calling 911 to go to the emergency department if things start to go awry. You also have to have one of 4 specific diseases: cancer, COPD, heart failure, or liver disease. And then in addition to having those diseases, you also have to meet disease-specific criteria. And these are really linked to evidence of advanced disease. So a particular ejection fraction, a MELD score if you have liver disease, and so on. And I should emphasize here that these are minimum criteria. Every Medi-Cal managed care plan was free to expand upon them, to open the benefit up to other folks, but at minimum, SB 1004 is available to folks who meet these three sets of criteria. And it should be noted, and I'll share a little bit more about this from the survey responses, that so far 81% of the plans have expanded eligibility criteria by loosening requirements on the evidence of advanced disease for the 4 existing conditions, or adding new conditions that they've opened up eligibility to, or both strategies. There are some specific services that SB 1004 providers have to be able to deliver. You have to provide advanced care planning support. You have to deliver a comprehensive palliative care assessment and consultation. There has to be a comprehensive palliative care plan of care. Care needs to be delivered by an interdisciplinary team. Someone on that team needs to take responsibility for care coordination. You need to be able to offer pain and symptom management. And you need to have the capacity to either provide or refer to mental health and medical social services. There are a couple other things that were recommended but not required, which are often part of specialty palliative care. So access to spiritual support, chaplain services, and also having 24/7 telephonic support available to folks in case something comes up outside of business hours. When would that ever happen? And if you have more questions about SB 1004 palliative care, CHCF put up a terrific resource center. This is a picture of it, and just put those words in your favorite browser and you too can find it. And I've circled one of the entries that's in the bottom left-hand portion of your screen, SB 1004 Basics. There's some terrific stream content in there, PowerPoint slides, written materials, links to useful spots, as well as a lot of information about how to, things that we've learned along the way in terms of facilitating implementation of SB 1004. So for the rest of my time with you today, I'm going to be sharing with you responses to those surveys that Kate referenced, a survey that we administered in February of this year that went out to all of the Medi-Cal managed care plans and as many of the contracted SB 1004 palliative care providers as that we could find. It builds on survey work that we did back in June of 2018 when the benefit was, when the program was still pretty new, and that we repeated in February of last year of 2019 when the program was about a year old. The surveys had about 25 questions. I think we had a couple more for the providers and a few less for the plans. And we tested the surveys with a couple friendly plan people and a couple friendly provider people before we sent them out into the world. And our intention was to really just capture as much information we could about SB 1004 activities on both the plan side and the provider side, beyond the information that the plans share with the Department of Healthcare Services, reporting on the number of folks who've been utilizing SB 1004 and a little bit about who they are and how long they used it and who delivered it. To our great delight, and again, thank you very much, 16 health plans, so that's about 2/3 of all, responded to the survey, and 27 provider organizations responded. We think that's about 50% of the contracted SB 1004 providers. That's a kind of a dynamic population and always flexing around a little bit. We don't know all of them, but we think it's about half of the folks who have contracts to deliver SB 1004 palliative care. And in the survey, and I'm presenting the findings today, whenever possible and when it's useful, we'll share with you the results as compared to the findings that we collected in early 2019, talking about what happened in 2018. So in terms of what's going to happen for the rest of this session and then later today, the survey covered a range of topics. In this session right now, I'm going to be going over plan and provider organizational characteristics. Who are these entities that are paying for and delivering SB 1004 palliative care? We'll talk about some of the structural components of their SB 1004 programs. We'll talk about referrals and enrollments. That's usually of great interest to folks, how many people are actually getting these services. We'll go into care models a little bit, payment models a little bit, and then just a little bit about approaches to quality assessment. And we'll talk a lot more about quality in the final webinar of the day. After this webinar, and when you've had a chance to refresh a little bit, Anne will come on and talk about the second set of survey content, getting into strengths, challenges, collaboration, and sustainability. So let's start by talking about the plans. So we have those 16 respondents, and they represent large and small Medi-Cal managed care plans 44% of them offer regional coverage covering single counties or a handful of counties. Don't assume that means small, because your one county that you cover could, for example, be Los Angeles County, which is quite large. 56% of the respondents were from larger plans that offer a range of products in addition to Medi-Cal managed care across California. And if you look at the number of adult Medi-Cal members covered by these 16 respondents, it ranged from 9,000, so not very many, to well over 1 million. So we have a big range of lift in getting SB 1004 off the ground across the plans that responded. As I mentioned, the plans, they took to heart that notion that they were able to expand eligibility as they saw fit. They couldn't offer it to fewer folks, but they could offer it to more, and they have done so. 31% of the plans added new eligible diseases, so made it open to folks with, say, neurological conditions, stroke, and so on. 13% expanded access within the original diseases, for example, saying, hey, you don't need to go look at the ejection fraction. That person has heart failure, I get their benefit, let's enroll them. And 38% of the plans did both. They both added diseases and expanded access for the original 4 diagnoses. Only 19% of the plans are using SB 1004 in its original state. And then offering comments about their approach to eligibility, many plans describe very flexible policies. Anyone that may benefit can be enrolled. Other terminal end-stage chronic diseases with case-by-case approval, all members with end-stage disease who meet the general criteria. And I should note too that 54% of the plans who responded to the survey cover palliative care service for their dually eligible members. And the plans beyond expanding the eligibility criteria, they're making investments into the SB 1004 program. 63% of them have engaged in efforts aimed at increasing enrollment of eligible members. That's been a very big focus for just about everybody who's been involved with SB 1004, providers and plans and policymakers and philanthropies. It's a big issue, trying to make sure that as many people who would benefit know about it and enroll. 63% have engaged in activities to educate and engage referring providers, not only teaching them about SB 1004, but also about palliative care in general, because there's quite a bit of, there's a knowledge deficit there, believe it or not. 44% have engaged in efforts aimed at improving collaboration with their palliative care provider partners. How can we work together better to make sure we're delivering this benefit in the service in as efficient and effective way as possible? And 31% have invested resource into analyzing their fiscal outcomes. Also, 88% have dedicated staff that oversee the palliative care program, and 63% of those staffers started the role in 2018. So they have a bit of experience now and expertise, and that's just evidence of how these programs are maturing. Excuse me. In terms of the networks that the plans are building, the range of palliative care providers that the plans have contracted with to deliver SB 1004 palliative care, it ranges from 1 to 17. About 20% of the plans are contracted with 1 to 3 providers, but 80% are contracted with 4 or more, with 10, with a full third being contracted with 10 or more providers. Now, a lot of the providers have contracted with multiple plans, so we asked the plans, well, how many providers do you have? And when we added all that up, just from our survey respondents, there were 106 contracts to deliver SB 1004 palliative care just amongst the plans who responded to our survey. And we asked, well, how many of those vendors, how many of those contracted providers actually delivered services in the last quarter of 2019? Is this an active and used network? Well, about 60% of those contracted providers wound up delivering care in the 4th quarter of 2019. Let's talk about the providers a little bit. 89% of them, and as I said, I think they had 27 respondents to the survey. 89% of them are affiliated with independent organizations, that's for-profit and nonprofit entities that are not affiliated with health plans. 11% are part of larger health systems, not health plans. 78% of them are from hospice, home health, and palliative care organizations. I hardly know what to call you guys anymore. You all offer so many different services, but generally an entity that also delivers hospice and or home health care. And the remaining groups, providers, are from medical groups that obviously do a whole bunch of things. And also there's a few specialty practices where the only thing they do is offer serious illness care. And these entities that are providing SB 1004 palliative care, they're offering a range of services to seriously ill individuals. 78% offer hospice care, 33% home health care, 26% operate standalone advanced care planning, education, and support programs. They also, a minority, offer hospital home transition services, and just a handful offer private duty nursing and also home-based primary care. But this actually gives me a lot of hope, these findings do, that palliative care is being integrated into this menu of supports that can be delivered to individuals with serious illness, and we can flex in and out of different care models depending upon the needs of the patient.
Kathleen, this is Kate,
Yeah.
and I received one question which I thought would be easy enough to answer in real time. If you go back
Sure.
2 slides.
Done.
Yes. So on this slide, there was a question on your last bullet where it says 60% of that network was used in Q4. There was a question that asked what happened to the other 40% of contracted providers. So
Yeah,
could you describe what you think that question means?
That's an awesome question. And the very short answer is, gosh, I don't know. It could be that some of them no longer are contracted providers and they've been discontinued, or it could be, for example, if you're operating in a small rural county and maybe there's only 10 people in a given year who might need palliative care. It could be that nobody came up in that time period. It could be that there was just generally few referrals even in a more densely populated area. There's a lot of things that could explain why. And one of the things I wonder about is, gosh, could that capacity have been utilized? And also, I think generally, is the network the right size? Are there enough patients to go around, given the number of organizations that have been contracted to deliver care? So sorry, I can't give you a better answer to that, but we can maybe put that on next year's survey. And also, if you want to put into chat any hypotheses that you have about maybe why that other 40% wasn't used.
There was also one question that just came in asking if part of this may have included pediatric palliative care providers, but our survey did ask specifically about adult palliative care providers. It did, so yeah.
It could be that was missed by some folks, but I think generally I think we had adult 6 or 7 times on each screen, so hoping that didn't happen. Certainly possible.
Thank you.
So, sure, no problem. So another thing to note about the SB 1004 provider groups is that they're serving way more than just the Medi-Cal managed care enrollees. They 89% have contracts with commercial insurances to offer palliative care. And I should note, we asked specifically about, do you deliver palliative care to individuals with other insurance coverages? So it isn't your hospice service or your home health service. This is offering palliative care. 67% of them, so 2/3, are engaged with Medicare Advantage plans. More than 60% also serve fee-for-service Medi-Cal beneficiaries. 52% offer services to Medicare fee-for-service beneficiaries. 48% offer care to those who have no insurance at all. So thank you all for doing that. And 29% serve dually eligible individuals. In terms of the reach of these services and the experience of the provider organizations offering palliative care, these teams are delivering palliative care in patient homes. Obviously, most of SB 1004 palliative care, the overwhelming majority, is offered in the places that people call homes. But 78% of the programs also offer palliative care in nursing homes, assisted living facilities, and other types of community-based facilities. More than 1/3 of them also offer services in acute care hospitals, so they're filling that role of inpatient consultation services, and 11% offer palliative care in physician offices or clinics. In terms of where they're spread out around the state, there is in fact one organization that has the capacity to deliver palliative care in every single one of the 58 counties in California. So the range of counties covered by our responding organizations is 1 to 58. 22% of the provider organizations offer services in just one county, so smaller local organizations, but 11% of the respondents offer services in 15 or more counties. So we have a big mix of the small and the large that are delivering SB 1004 palliative care. terms of the length of time delivering palliative care, more than 40% are still kind of new at this. They've been doing it for 1 to 2 years, but that means that almost 60% have been doing it for 3 years or more, which I think is really a sign of a maturing field, maturing clinical capacity, a lot of expertise in that group. Providers, just like plans, are also investing a lot in being able to deliver SB 1004 palliative care. 88% of you all, of the SB 1004 palliative care providers, invested in providing training to their staff so they could deliver this type of care. More than 40% made an informatics investment, so investing in the new electronic health record or a billing system. 46% hired new staff to do billing or engaged a vendor to do billing. More than 70% hired additional patient care staff, which makes sense if you're adding on a new clinical service. But 62% also hired additional administrative staff to help to run the program. And 62% made the investment to secure certification in palliative care from the Joint Commission or from CHAP. And then 73% have dedicated outreach staff who engage with potentially eligible Medi-Cal patients and or with referring providers so that folks can learn about their palliative care services and also learn about palliative care generally. In terms of how many contracts these providers have, more than 40% still just have a contract with one plan, but almost 60% have contracts with multiple plans, including almost 30% were contracted with three plans. We have 8% that are contracted with 5 plans or more. And this, I think, just highlights what, the benefit of being in an area where there are multiple plans that offer palliative care. It also highlights what can happen if plans tweak the program or other programs, and you wind up with 6 different versions of SB 1004 palliative care that all aren't quite exactly alike, but you need to try to meet all those needs for the luxury of having multiple contracts and therefore a larger number of referred patients. How are providers paid for SB 1004 palliative care? And here I'm contrasting the information that we gathered that talked about what was going on in 2018 with this information that we just gathered that talks about what was going on in 2020. And what you see on the x-axis are different mechanisms for paying for SB 1004 palliative care. And then I'm showing the proportion of respondents in each year that endorsed using one of those models, using that model in at least one of their contracts for delivering SB 1004 palliative care. And the blue bars are from 2019 and the orange bars show 2018. And this 2020 survey we did talked about 2019. So you'll see that 35% of the respondents had at least one arrangement where they were just getting straight fee for service Medi-Cal for delivering SB 1004 palliative care. I don't know how they do it, but they do. And that's up a bit from the proportion that endorsed that in our last survey. That may just have to do with the differences in the providers who responded. It may not be actual, all of these may not be actual trends, though hard to tell. 85% of our respondents this year said they have at least one contract where they're receiving per enrolled member per month payment, so a case payment for delivering the SB 1004 palliative care. Much easier to manage and much easier to deliver, to meet all those demands of the required scope of service if you have a case rate versus a fee-for-service schedule. And that's up from the 72% that had at least one contract like that back in 2018. 69% of the respondents say that they get a separate assessment fee when they go out and evaluate if a person is appropriate for enrollment in SB 1004 palliative care, and that payment is made even if the person doesn't enroll. And that's been a really important innovation, and it really made me happy that that was more broadly available, or appears to be more broadly available, because that can be a lot of effort on the part of a provider to do those assessments, and if the patient doesn't enroll, then they wind up losing quite a bit of resource. It can take several hours to do those assessments. That's up from the 41% that had that sort of arrangement in at least one contract in 2018. There's also an increase in the number of folks who had at least one contract that had a fee-for-service add-on. So that's for those patients who just wind up using so much service, excuse me, they need so much help that even with a generous case rate payment, you just can't give them all the care they need and not lose quite a bit of money doing so. And so plans have said, hey, if we have a super utilizer, we'll go ahead and add on a fee-for-service payment to help take care of those costs, to help make you whole. That's more than double the number of such arrangements that were endorsed in the 2019 survey. And then also there's a bunch of providers and plans that have made arrangements to get incentives for hitting certain targets. And these typically have to do with healthcare utilization, submitting data so everybody can keep track of quality indicators, for completing advanced care planning chores. And also there was one provider that had a contract where they were had an incentive related to member satisfaction. Who's delivering the SB 1004 palliative care for these provider organizations? Well, we asked which disciplines on your team are directly and routinely involved in delivering services to your SB 1004 patients. 96% of the providers said that they used a social worker and an RN directly and routinely, and that is no surprise. 88% had a physician directly involved in care. 73% a chaplain, and I think that that's a fantastic number. And I think a lot of the reason why that number is so high is because so many of these provider organizations also offer hospice care. They have chaplains handy to help to draw on to do this work. 69% using a nurse practitioner, 54% a licensed practical nurse or licensed vocational nurse, 46% were using home health aides in delivering SB 1004 palliative care, though one of the larger plans does require that across the state across all their business lines. So I'm not surprised that that's a little more prevalent these days. 19% are using community health workers. I wish that number was higher. 8% using pharmacists, 12% physician assistants, and nobody this year said they were using a psychologist. And we went through and we looked at these providers that were endorsed, and it turns out that 92% of the provider organizations say that they're using 4 or more disciplines routinely in delivering these services to their patients. And 69% are using that classic model of the provider. So a physician or a nurse practitioner paired with a nurse, paired with a social worker, paired with the chaplain, sort of the big 4 that you see in, say, the Joint Commission certification to deliver SB 1004 palliative care services. So really good practices in terms of constructing and using an interprofessional team. Now we get to the juicy stuff. How many people are actually being referred and how many people are getting services? So we'll start with the plans. So in our 2020 surveys, which refers to activity in 2019, you'll see that almost 25% of plans were still only getting 1 to 50 referrals for SB 1004 palliative care. So this is not folks who actually were served, but just who was referred for evaluation for enrollment in the program. 23%, about 100 to 200, so that's pretty good. 8%, 200 to 300. 23%, about 300 to 500, and 23% of our responding plans got more than 500 referrals to SB 1004 palliative care, which is great. The range in this survey was 7 to 796. And if you compare this to what we saw in 2018, there's still exactly the same number. 23% of plans had 50 or fewer referrals in the course of an entire year. And that's struggling. That's not as many as I think anybody would want. But the good news is that the plans that had more than 400 referrals in 2018, that number was only 15%. In 2019, it jumped all the way up to 38%. So we're definitely seeing, at least among the respondents to this survey, a trend towards a big increase in referrals. We saw some of the same trends for the provider organizations. In 2019, 41% still only received 11 to 50 referrals, and 5% had 0 to 10. So very underutilized. They may have been in that 40% who weren't utilized in Q4. 23% had 51 to 150 referrals, 18%, 151 to 300, and 14% of our respondents had more than 300 referrals to their SB 1004 palliative care service. The range here was huge, between 8 to 2,000, and part of that is, if you are Kaiser, you're going to have quite a few referrals. If you are a provider organization that's delivering care in 15 counties, you would expect to get 2,000 referrals. In terms of the very low number of referral provider organizations, in 28%, in 2018, 58% of the provider organizations had 50 or fewer referrals. In 2019, it didn't go down by too much. It was still 46%. But amongst the provider organizations that got more than 150 referrals, that was only 16% in 2018. That bumped up, that doubled to 32% in 2019. So a general trend towards these folks getting more referrals to their services. In terms of the number of folks who actually received services, so that referral was received and evaluated, the service was offered to the patient said, yes, sign me up. How many folks were there? So you can see the distribution is pretty wide, and as you would expect if you saw the range in the number of referrals. It's still the case in 2019 that more than 20% of the plans enrolled fewer than 25 patients. And that's up a bit from what we saw in 2018 when 15% only enrolled 25 or fewer patients. In 2019, 7% of the plans enrolled 26 to 50 patients. But then you see a nice wave towards the right side of the graphic, where you have 28% enrolled 101 to 150, 21% enrolled 151 to 300, 7% enrolled 300 to 400, and a full 28% of the plans enrolled more than 400 people, which is a very nice bump. If you tally up all those numbers and you consider them in comparison to what went on in 2018, according to information that the Department of Healthcare Services shared, about 2,900 individuals received SB 1004 palliative care in 2018. Now, if you look at the total number of individuals that received SB 1004 palliative care in 2019, as reported by the 14 plans that shared their enrollment information in our survey, that number alone exceeds the total for all the plans from 2018. That totaled out to over 3,660 individuals receiving care just from those 14 plans. If you look at either the median or the mean, or you use a variety of methods, and you say, well, what does that mean for all 24 plans if we only heard from 14? My best guess, and we'll know soon enough how close this is that somewhere between 5,000 and 6,000 individuals received SB 1004 palliative care in 2019, a huge and impressive bump over what happened in the program's first year in 2018. Now, the less exciting news, or news that's hard to interpret, is the enrollment rate. So we asked the plans, how many adult Medi-Cal members do you serve? And that's the population that's eligible for SB 1004 palliative care, at least the part that we're looking at, adult Medi-Cal members. And then we use that as the denominator, and the numerator was SB 1004 enrollees. And the rate of enrollment for the adult Medi-Cal member population is actually very, very low. It's 0.004% was the lowest enrollment number that we saw. And at the high end, the highest one that we saw was 0.379%. We don't quite know what the exact right number is. We don't know how close that is to the number who actually are eligible. We do, I think, generally have a sense that we can probably find more people who would benefit from this. So I don't think we're anywhere near topping out. If you look at the providers, how many patients are they serving in year 2 of the program? In 2019, we had somewhat fewer, serving 25 or fewer, 32%, as opposed to the 45% that was seen in 2018. 26 to 50 individuals served across the course of the year was 9% in 2019. And then again, we see sort of a general increase in the bars that are on the right-hand side of the graphic. So 23% saw 51 to 100, up from 7% in 2018. 23% saw 101 to 150, up from 14% in 2018. 5% saw between 151 and 300, and a full 9% of the provider organizations delivered services to more than 400 people, which is fantastic. If you look at the work that plans and providers are doing to think about evaluating their programs, efforts that they're putting into assessing what's going on. Well, the plans did indicate that they had intentions to assess the value of their services. I should note that the original title of this slide was Plans the Plans Have for Assessing Value. I thought it would be very funny that Kate Myers made me change it. So I guess your loss, my loss. We asked in the survey, in the coming year, will your plan conduct any of the following analyses for your SB 1004 palliative care program? And half of the folks responded that, yeah, we're going to take a look at our fiscal outcomes. More than 70% said they're going to look at their utilization outcomes. Only 20% said they're going to look at clinical outcomes, and that's a little harder for the plan to do. They may not have access to those data unless they're partnering with their provider organizations. And 43% said they're going to take a look at the impact that SB 1004 palliative care had on member experience of care. 64% of the plan respondents said they intended to do at least 2 of these analyses. So again, plans investing their resources, their time into attending to this program, seeing how they're doing and how they can make it better. In terms of practices around quality assessment for gathering information, we asked the plans what information that they asked providers to report to them about specific outcomes. You know, and they're asking their provider partners to offer a whole bunch of different types of information in different concentrations. So 36% say they ask about timeliness of service, 43% look at assessment and management of physical symptoms, half look at psychosocial needs, 36% ask for information about meeting spiritual needs, 50% ask about assessment and documentation of goals of care and advanced care planning, 57% look at discharge status, and 36%, hey, we don't ask our providers to give us any information. And it should be noted that when we asked plans about things that we're concerned about, only one flagged quality of care members are receiving as something that was on their mind, that they were concerned about. 85% of the SB 1004 provider organizations said they have a formal quality assessment and performance improvement program for their palliative care service, which is awesome. We also asked them about a range of metrics. Are they using those to assess the value and the quality of their palliative care program? And most every provider endorsed most every type of metrics that we put forward, everything from days between referral and initial visit, down to completing pulse forms and advanced care planning conversations, to completion and timeliness of medication reconciliation. So a lot of good quality assessment activity happening. In terms of reflecting on these data, this information about who is getting served and how, I came up with a number of things came to mind for me. One is that, yeah, referrals and enrollments are increasing in a really impressive way. That the plans have expanded eligibility to more seriously ill people who will very likely benefit greatly from making use of these services, that the plans and the providers are investing resources, administrative effort, outreach effort, quality assessment effort into their programs, that most plans contract with multiple providers, and now a lot of providers are contracting with multiple plans. So things are becoming more secure in regions for the folks that are delivering these services, that the providers report having robust interprofessional teams, and that fee-for-service is not the dominant payment model for this care, which is great because it's really hard to sustain in that model. The providers and plans are using a range of payment mechanisms, including assessment fees, case rates, and incentive payments. And my questions that I had, and I do have a minute or two if any of you have questions, is, you know, the enrollment target is really on my mind. How many people should be receiving SB 1004 palliative care, and can we please get a denominator? It'd be really good to know if we're 10% of the way there, 30% of the way there, 50% of the way there, or 80% of the way there. And I also wonder about those barriers that are keeping enrollment low for some plans and some provider organizations. Why is that happening, and are those things modifiable? And I'm hoping that in the coming year, in 2020, we can make some progress towards answering those questions that I have. And I think we have like a minute or two left. If Kate, if there's any questions that came up that you want to put forward to the group, I think we have a minute or so for that.
Sure. Thank you so much, Kathleen, for a great presentation. There were a number of questions and comments that came through during the chat, during the presentation, some of which we responded to in real time. A couple of them towards the end were reflective of what you just articulated, Kathleen, as your own question of sort of a couple of folks commented on. It does seem reasonable that we should have a better sense of what how the eligibility for SB 1004 compares to the actual enrollment, and what is the estimate for what we should be aiming for. So I think your response to that already is that, yes, that's something we need to continue to be working on so that we have appropriate targets. A couple things I'll mention so that people can get their questions answered perhaps offline, and I'll add one more in a moment. I'll leave the webinar up for a few minutes after this ends so that you can type in additional questions that we could follow up with you individually on if necessary. So just keep that in mind. A couple of comments came up further back up in your presentation. One I think is a pretty straightforward question, so I'll ask it. When we were talking about payment approaches, there was a question about whether the fee-for-service add-on incentive selection was in addition to a PMPM contract. Is that what that meant, as an add-on to what?
Yeah, that's exactly, yeah, sorry for not explaining that better. That was explicitly phrased in the survey, in addition to a PMPM payment for patients that utilized services that exceeded the usual effort that could be covered with the PMPM. And this is like for super utilizers. So yeah, it was an add-on.
Thank you. There were also some questions that I think require some more conversation about how to, from a health plan, how to help convince leadership to move to PMPM from a fee-for-service structure. So I think we're going to follow up with that questioner individually offline because it's intriguing and complicated. And then just one final clarifying question around the referrals data. There was a question about, did these referrals, these numbers of referrals, refer to Medi-Cal only or Medi-Cal plus Medicare plus commercial? And we did respond in the chat, but just wanted to make sure everyone was aware. Those numbers did explicitly ask about Medi-Cal referrals, SB 1004 referrals.
SB 1004 referrals, yeah, exactly.
Yeah.
So and the one thing, we can't answer that completely. Just one thing I want to say about the moving from fee-for-service to a more appropriate payment model or more manageable payment model. There's a whole bunch of plans that are offering that now, a whole bunch of Medi-Cal managed care plans. So there's a great opportunity for peer-to-peer learning there. You can talk to somebody who's taking care of the same patient population, administering the same benefit, and get some tips on how they did it.
Wonderful. Okay, so since we are 2 minutes past our end time, I will again say, please, folks, if you have some remaining questions, please type them into the chat and we'll do our best within the next few days to follow up with people individually with thoughts and responses. And in the meantime, I hope that many of you will be joining us for our next webinar, or our next two. The next one starts in just under 30 minutes at 11:15, and that will be our webinar focusing on looking ahead and what we've learned from the surveys from plans and providers about continuing priorities for this work and opportunities for improvement. And Dr. Ann Kinderman will be presenting on that. And so we'll see many of you in 30 minutes. And for those who are unable to join for subsequent webinars, know that the recordings and slides will be available on the CHCF website, likely within about 7 to 10 days. And everyone take care, and we'll talk to many of you in 28 minutes. Thanks so much.